Everybody, thanks for joining. We're going to close out this week on the Global Child Health Lecture Series with a talk from Devan Jaganath. He is, I would say, one of certainly UCSF's expert, if not one of the national or world experts on pediatric tuberculosis, and in particular, the diagnostics of that, diagnosing PEDS TB, particularly in settings where you don't have all of the resources that one might have in other places, can be quite challenging. And there's a number of benefits and challenges with each emerging tool. And Devan has really been at the forefront of investigating and learning about those tools and trying to identify which are the best sources going forward. So every year he presents updates on that general area, including thinking about how to develop partnerships in global health and how to think through digital health more generally. So I'm very excited to see what he has to share with us today. Thanks.
Thanks so much. And I guess, we have a small enough group and I don't have that many slides. So, I don't know if we want to just introduce each other again. My name is Devan Jaganath. I don't know if we want to start over here.
I'm
Great. Welcome.
I'm one of the second years.
Wonderful.
Jason, one of the second years.
Great. Jason. And Tiffany. I think Joshua. Josh, you want to just introduce yourself? We have a kind of a small group.
Yeah, hi, I'm Josh. I graduated UCSF and I work now in decision support for digital tools. Thanks.
Oh, great. And then Fritz.
Yes, I'm Fritz, pediatrician. I was working in Haiti. I'm currently living in the United States, in Connecticut. I work with a child in HIV program, MTCT, and I'm very interested to hear about this topic.
Okay, great. Yeah, I think everyone, I'm sure, has a lot of their own experiences and frustrations with digital health tools in general. And so, yeah, hopefully this can be somewhat interactive for me to learn also. So overall, I want to just talk about what is the role of digital health tools that can play in tuberculosis care for children, discuss some of the examples that I'm currently working on, and then I think there's just a variety of factors that we need to consider on a global health kind of scale when we're thinking about implementing any of these tools. So just to kind of first define digital health, because I think it's a huge topic and I myself am sometimes confused in what defines it. I just kind of gave what the WHO is considering it is, the field of knowledge and practice associated with the development and use of digital technologies to improve health. So super broad, pretty much anything that can use the digital technology to improve health. And FDA has a whole regulatory aspect of this, and that hits everything from mobile health, what used to be called electronic health, information technologies, electronic medical records, or even the connectivity of systems, like diagnostics or other kind of data systems in place, wearables, sensors, telehealth, and then kind of more personalized medicine. So really runs the gamut. And then, I just want to make sure we're all talking about the same thing in terms of tuberculosis. I don't want to assume everyone has that kind of experience. So, TB is an infectious disease. It's caused by this Mycobacterium tuberculosis complex, which is a variety of different bacteria, of which the most common is Mycobacterium tuberculosis. It's primarily transmitted through respiratory droplets that get inhaled and then either can cause a pulmonary infection, but can disseminate to other places. And super interesting disease in that, can really run the spectrum from spontaneous clearance to kind of a controlled infection that we now, currently define as latent TB infection, or you can have symptomatic disease. And then for those that have kind of a more controlled infection, they can later on progress, right? And what, reactivate, as it's called, to have active disease. And globally, it's a huge problem. 10 million cases estimated annually. From this infection perspective, about a quarter of the world is thought to have been exposed and infected by TB. Huge cause of mortality globally. And I guess slightly maybe a little old, COVID overtook TB as kind of the #1 infectious disease killer globally. But I think as we'll continue to learn, especially as COVID deaths go down, the health system is completely impacted as a consequence of this, and TB is definitely included in that, and we've seen huge drops in case notifications and rises in mortality. So huge problem. Oh, the slides are very small on the top of the screen. Looks okay for you, Tiffany? Do it. Okay, let me know if I need to stop sharing and resharing, because I can do that. And then, so how can digital health maybe play a role in overall TB care? Again, with this broad definition, you can imagine it hitting kind of a variety of areas in the overall care cascade, whether it's helping on a diagnostic level of, using mobile phones to find patients and communicate with them, education, improving intersects of diagnostics, like I said, lab results. There's whole systems in place to get results faster to patients, clinical decision making from again, a diagnostic perspective. There's just overall, how do you use it to support medication and stock, medication stocks overall. There's how do you support adherence, right? And there's a whole category called digital adherence technologies that I'll mention a little bit about. And then, from an advocacy standpoint, you can imagine you can use digital health also for that. And so there's a huge interest globally to how we can leverage digital health for supporting TB. And this includes for children. So, how could this help decentralize care for childhood TB? Because I think, the TB symptoms that children often present with are very nonspecific, right? Fever, cough, failure to thrive. And it's most appropriate that they should be just going to their regular primary providers or a lower level facility to get evaluated and get the care that they need. Unfortunately, given some of the challenges, particularly in TB diagnosis, there's a huge shift, of that care to more tertiary settings, and that creates delays because it's usually multiple visits for them to actually get the care that they need, and delays in initiation of treatment. And when we think about the burden on children, about 230,000 die each year from TB. Almost all of them are because they didn't get the treatment. So if we can decentralize care, move it more to lower level facilities, we really could reduce that burden. And then when it comes to actual treatment, kind of the standard that some may be familiar with for TB treatment is something called direct observed therapy, which has a lot of barriers, right? The idea of having someone come to a clinic regularly, get medications, observe, that could be really a challenge for both patients, adolescents, as well as caregivers, that prevents them from maintaining their adherence. And so digital health tools, you can imagine, could support both providers at this first line in terms of helping them with clinical decision support, but then also, caregivers and patients from a treatment support perspective. And then there's also, again, this TB infection. As I said, a quarter of the world is impacted by this, and California is not immune from that. Actually, something around 20 million people are thought to be infected with TB just in California. And so how can we improve that care cascade? Because for children, we know that if they've been exposed, they have a much higher risk of progression to disease. They can have more severe presentations like TB meningitis. They're the reservoir for future TB disease, right, that later reactivate. And also there's benefits, right? They tend to have less comorbidities. They tend to tolerate the medication much better. And because of all these factors, the American Academy of Pediatrics actually recommends that we should be screening annually as part of well child visits for TB. And so if we're shifting again to more primary care providers, digital health tools could be a useful tool to kind of help provide that decision support to allow them to complete these activities. So kind of shifting to now, what are some projects that I'm working on? Hits a few different categories that I'll talk about. One is triage and diagnosis, and talking about kind of some artificial intelligence or AI tools for X-ray or cough and lung sounds. Next, looking at treatment support, so more specifically digital adherence technologies and treatment monitoring. And then going back to latent TB infection and the role locally that we're working on with electronic health record-based tools for that. So brief primer on chest x-rays for TB. So again, as I mentioned earlier, pulmonary TB is the most common type of TB, even for children, and chest x-rays are commonly part of that evaluation. However, you can imagine reading an x-ray has its challenges, especially for children. It can be very non-specific. There's a lot of there's poor inter-rater reliability, so it's quite variable. And in low resource community-based settings, again, if we're moving to a more community-based approach, then you may not have a radiologist frequently, and definitely people that maybe not have the expertise for reading pediatric x-rays with a focus on TB. So there's been this huge movement in something called computer-aided detection for TB, which utilizes these deep learning or AI models to try to predict abnormalities as well as give a probability of TB disease. And so there's actually a huge number of vendors, more than 15 that have developed these, and 10 that are certified, and many that are actually on the market now. And there's just an example. And many of these use digital x-rays where you can upload it, and with kind of a basic system, it gets automatically read, and you get these kind of heat maps that show abnormalities. This is just one example of vendor Lunit, but there's a variety of others that all do fairly similar things. Again, give kind of heat maps, give kind of probabilities of certain abnormalities, and then an overall probability of disease. In terms of infrastructure for an x-ray machine, there's also been in parallel large developments in some of these ultra portable x-ray devices, which are pretty cool, where you could, which are quite compact, and again, could be connected to as simple of a computer as like a Raspberry Pi or a laptop, and they could, do all these things. So sounds great in some way. Overall, yeah, go ahead. Yeah, please.
X-ray machine, portable,
Yeah,
and in the size of that?
yeah.
Is that palm size?
So I can show, this is kind of a picture of it. So you can kind of connect and then we do it.
Thanks.
Yeah, so there's a few different devices that could really reduce it. Others have like made a backpack where they could put all these things all together. So, there's been a lot of development in trying to make more portable systems, recognizing there's still like certain other requirements like continuous battery power maintenance, and cost of any of these items is quite variable. But from a performance standpoint, for adults, overall the sensitivity is pretty high, specificity is moderate, but comparable to a human reader, because in some ways, again, the goal is to see, like, if you had a radiologist or you had someone with expertise, they could be able to read it. In settings where you don't have this, could this software provide similar support? And so the short answer is, it seems like yes, it can. And so a big thing that happened this last year is the World Health Organization actually recently endorsed CAD as a TB screening and triage tool for adults. So now the question is, like, how do we implement that and evaluate it? But there's really a gap for childhood TB. So a lot of these models utilize like tons of x-rays in order to train it. But they're all adult x-rays, right? Which we know they have more reactivation TB, they present differently. And although there are some of these algorithms that have kind of indications, or they say that they can work from ages as young as 2, some is more likely kind of 6 and older, there's really not data to support that, or any data to show validation of this or to show accuracy. So I think that raises concerns that we do need to see how they're performing on it. And but there's challenges, right? We don't have a repository of x-rays that are well characterized that can try to improve the overall kind of performance, either see how they work or improve on the performance, because you can imagine you could try to retrain some of these models, fine tune it to a pediatric TB kind of prediction. So a project that I'm co-leading with the Desmond Tutu Child TB Center at Stellenbosch University in South Africa, and a nonprofit called the Foundation for Innovative TB Diagnostics, or FIND, is to actually build this repository. And so, basically create a consortium of pediatric TB investigators who've conducted high quality studies and have large banks of x-rays, like our study in Uganda, for example, has a lot of x-rays as well as others, and actually get everyone together, ensure that they're read appropriately, well characterized from a TB status perspective, and then create an infrastructure whereby we can, one, invite current CAD vendors who say their product works well for children and actually try to independently validate that and provide evidence for it. And second, create a bank of x-rays to allow these groups or others to develop their own algorithms, right? And I think there's been a lot of interest in this. And so this is kind of what we're working on over the next 6 months, is to build this repository and actually get it started and hopefully get some data in the next year or so. Yeah.
Compared to like a human reading, are you also incorporating like cultures?
Yeah, so both would be helpful, right? Depending on, I think, so the answer is both. So we'll have a radiographic read, in part because, again, if you think about the utility of this, it's probably to replace a human reader. So definitely a radiographic read is important. And so we're having these radiologists kind of overread a lot of these x-rays. And then also we have in pediatric TB, a big challenge is like a gold standard definition, because there really isn't a good definition. So there are these consensus definitions of confirmed, unconfirmed, or clinical TB or unlikely TB. That's the reason of reaching out to some of these diagnostic studies, because they've classified all these children, of which they do things like they're suggesting culture or gene expert, and they do follow up. And so both will be analyzed as part of this. I think sometimes you have to ask the question, like, again, what's the goal of this? And do we really think that a CAD algorithm is going to somehow predict, TB from a non-specific image? It may or may not, right? If it can, great. But I think even at a basic level, if it can perform similar to a radiographic read, I think that would really be valuable for TB as well as other diseases. I think we need to not be so siloed and just say like, look, a provider's just thinking about TB. It's like, okay, I think if it's found an abnormality or consolidation, that'd be valuable for a variety of respiratory diseases, right? So then moving from x-rays to sounds. So TB often has respiratory symptoms, cough, or can have sometimes abnormal lung auscultations. And oftentimes, we just ask people, like, do you have a cough? Or, we listen to someone's lungs, we say, okay, we hear some crackles, and that's like pretty non-specific, right? We just kind of say yes or no, or you've had a cough. But you can imagine that this is actually a pretty stereotyped, physiologic mechanism, right? Like someone could be coughing. So, now we're all very attuned to cough, right? Like someone would be coughing somewhere and we're like, we know it's a cough. And why is that, right? Because there is something unique about it, right? They're inhaling, they're then expiring against the closed glottis. And then the glottis opens and you hear this explosive sound that we all recognize as a cough. And that's a very kind of stereotyped pattern. And that we've actually, if you look at different diseases, whether it's infectious or non-infectious, these patterns actually can be unique. And so are we taking advantage of these sound changes in a better way than we've looked at cough or lung sounds before? And again, this is where deep learning or kind of machine learning approaches can be valuable, because you can take kind of a sound cough signal, make it into a image, basically, which is a spectrogram as a kind of a graph of frequency over time. And much like the x-rays, now this is a unique picture that can then be used to detect a cough automatically. So it doesn't have to be like we say it's a cough. Like if you can teach someone, you could teach a computer to say this is a cough and actually pull out key features and then use it to classify a disease, whether it's COVID or TB or other illness. So we would be interested in doing this for TB. And so, right now we're developing algorithms for that. And, but there's some questions. How do you integrate the fact that someone might be coughing 5 times? And what if one of those coughs are TB and 4 are not? How do you define them as what disease or not, right? That's a question with, it probably doesn't live in a silo, right? To think that you can somehow define cough alone as the disease might be challenging. So why not utilize clinical variables to improve the overall performance? And then, you know, longitudinal collection is actually pretty attractive, right? Because you can see maybe more patterns than a single time point, especially if it's on something like a mobile phone. And so how do we best do that? And so something we're currently doing in 5 countries currently is collecting cough sounds in Uganda, South Africa, India, Vietnam, and the Philippines. And so we do this in adults and children, in which we use a mobile phone app called Research that allows us to collect and record cough sounds. And at baseline, it's really simple, you know, you just have it like a tripod in the phone and have them cough, and you can collect it. And if for more longitudinal recording, you can see that it can capture coughs continuously. We have made a little stylish bag for adults, and they walk around for a couple weeks, and they give it back to us, and we get kind of overall cough patterns. And then for lung sounds, we have we're partnered with this company called Medicine, which has developed a digital stethoscope called Steffi Pro, which allows us to via Bluetooth record lung sounds using this digital stethoscope. And we're doing this in children, so you can see in this picture here, you can, you know, pretty easily just use it as a stethoscope, but you can also just put it on them and it'll kind of, again, collect lung sounds at different locations. So it's nice in that it's non-invasive, it's simple, it doesn't require blood collection or urine collection. And the other reason I think these are really attractive is you can imagine that then you can involve multiple groups, right? Like oftentimes you have like one sample of plasma and you're somehow trying to decide, like, you know, which ideas or projects you want to do. If there are 4 or 5 groups that are interested in developing a cough sound model, potentially they could all be involved, right? Like, you know, there's no reason that you can't share something to different groups if they are thinking about it in different ways, and, you know, allows you to be agnostic to the overall process. So that's really an advantage, I think, from thinking about digital biomarkers in general. I want to shift from diagnostics to treatment support. So digital adherence technology is another huge category that has gained a lot of interest over the last few years. And the kind of overall goal is to support treatment adherence and not require, again, a person necessarily to have a person visit them every single day, or for them to have to go to a clinic, which has kind of been the current model for TB treatment. And this really, again, just like digital health, has a huge spectrum of options. It includes smart pill boxes where, you know, you can either open a pill box, or it's like a larger pill box where there's alerts and reminders. And there's video DOT, which actually is done pretty frequently in the US, where they actually video them taking the pill, and then that gets kind of monitored as opposed to having to go in person. And then there's phone-based approaches with these medication sleeves and labels. And that in particular is something we've been working on, is a program called 99 Dots. And the way this works is in a standard TB medication regimen, you're given these blister packs essentially, and you open it up and you take your pill. And so in these blister packs, we have a sleeve that goes over it. And when you open to take your pill, there's a kind of a toll-free number that you can call. And that counts as your kind of documentation that you've taken the medication. And so we've evaluated this in a kind of a large implementation trial in 18 facilities in Uganda. And overall, it was similar to standard of care, though on the per patient analysis, there was a higher likelihood of treatment success using this 99 Dots program. But most notably, this was all done in adults 18 and older, but this was an implementation trial. And so adolescents, really 10 and older, that could take standard medications, were using the same blister packs, and they could also enroll in 99 Dots if they wanted to. So that creates an opportunity to try to see, like, maybe this is valuable for kind of older children and adolescents. And I think we can all appreciate that adolescents may benefit from digital adherence technology. I mean, I think they have a lot more comfort with technology. They might not want to come to a clinic, both for privacy reasons or concerns for stigma. And they have other things they'd rather do, right? Go to school, work, do other things. And so this could be really attractive as an option from the standard of care. So that's what we're currently doing. So we're doing a secondary analysis of this trial with some important formative work. We're interviewing adolescents that participated in 99 dots, those that haven't participated, their caregivers, to really understand kind of outcomes, in terms of the adolescents that did use the program. And then what were the facilitators and barriers to inform kind of further digital adherence technologies for adolescents, because it really hasn't been a focus of the kind of current landscape, despite I think many kind of attractive options for them. So so far, in this program, there's actually 441 adolescents that have actually participated in this, and a large proportion did use 99 dots, and 92% of them were able to complete treatment successfully with this program. And so I think, like I said, it'll be really interesting as we go through this analysis to see how it's performing currently, but I think more importantly, how we can tailor this more specifically to this population to give more adolescent-friendly services, which for those that aren't as familiar, in many of these settings, child is defined as like less than 15 or a little bit younger, and then adult is kind of 15 and older, but it's not really tailored to that 15 to 19 population. And so there's a huge need for better services and integrated not only with TV, with other issues in order to kind of better support them. So this would be one option. And then the last thing before moving to latent TB infection is kind of treatment monitoring with cough sounds. So I think overall, when we think about getting treated, you'd expect their cough to get better. But again, we ask people fairly subjectively, like, did your cough get better? Got it better? And I think that's hard for a person on the day-to-day basis to really quantify in any real way, like, are they, getting better a little bit, a lot, and you can imagine that could be helpful if you're trying to get a sense of, hey, are they not responding to therapy, or they are. And so again, we can use these continuous cough monitoring maybe to support that. And this is just some preliminary data that kind of shows that for adults, we are seeing kind of trends. One, that those with microbiologically confirmed TB, it is going down on treatment, and it's different from if they had a more clinical TB diagnosis or didn't have TB. And so there's clearly a cool kind of trend that you can see where they're responding to treatment, and that maybe the pattern is different if they have confirmed TB versus other disease processes that are going on. And so, how could this be used for children? I think really could be interesting, again, to have a better monitoring tool than we currently have. I think the challenge is right now we're really just using these smartphones, right? And that's not really feasible for a young child to be walking around with like a smartphone around their neck, for 2 weeks. And so I think as, more wearables and other sensors get developed, this is kind of an exciting area to try to think about how it might be valuable for children. Okay, and then so the last kind of section is really around the latent TB care cascade. I think I wanted to highlight this because while it's a global disease, it really impacts us locally. And this is actually something we're doing here in the Bay Area, is kind of how can we use electronic health record tools to improve the LTBI care cascade. And there's a variety of benefits, whether it's screening or guiding testing and treatment, improving documentation of completion. Like, that's a huge problem. People find it very difficult to figure out whether an individual was treated and whether they completed it or not. Giving educational materials to patients, better monitoring for just overall patient navigation, and overall just trying to create an infrastructure for better quality improvement, but also communication with local and state public health officials who are trying to kind of think about interventions to support care. And to that point, there actually is a California TB elimination strategy, and a big part of that is that they've called for electronic health record systems for latent TB infection in order to help support that. There's one problem. There's really no tools in Epic or in our system, Apex, to do this. And this is a national problem. There really aren't kind of a standard set of tools that could be there, and that, LTBI hasn't traditionally been put at the same level as other health maintenance tasks, which you could ask why, right? It's not that different from screening for other diseases. You screen on a regular basis. If they have a risk factor, there's a test to send, and if it's positive, then you can go in a different direction. But for most people, it'll be negative, right? So it's like, why aren't we treating this like any other health maintenance task? To that end, so we created some tools for pediatric latent TB infection. This is over at Children's Hospital Oakland, where they have an FQHC, or Federal Qualified Health Center, where they see a huge number of children each year. And they even have an international clinic where they see recent immigrants and asylum seekers. So they themselves have been pretty interested in TB screening and have tried things in the past. And so we really working with them and other partners, we decided to make two kind of workflows for the primary care setting. One is just routine screening, again, like health maintenance task, like they need to just do their annual screening as part of their well-child check, and how do we support that? And then for those that have a positive test, you can imagine that's a different workflow. You know, a minority of the children that come through will have that, and maybe they need more decision support help in those situations. So for the first routine screening, again, is just a well-child visit. You need to just kind of, how does it fit within your regular health maintenance workflow? How do you do screening? And if they have a screen, how do you support ordering the appropriate test? And so something that, you know, some may be more familiar with is that there's these care gaps in EPIC, which is just kind of your list of to-dos, like your vaccines, or if you're, you know, for older people, diabetes, cancer screening. It's just kind of like your annual screening checks. And so again, you know, we need this TB to be part of that. And so for the first time now, TB risk screening is part of the care gap that'll appear once a year with the well-child visits. And if they click it, they can get kind of a snapshot of past responses. There's nice kind of guidelines for the California LTBI guidelines, but also like UCSF has some treatment guidance. And then to clear that care gap, you would complete a screening. So we have now in our rooming tab, so this can be done by a provider, but also by like a nurse or a medical assistant, kind of 4 simple questions about kind of whether they were born or lived or traveled in a TB endemic setting, or if they are currently or plan to be immunosuppressed, or if they've had contact with a person with TB. And for most people, they'll click no, the care gap will clear, and they've done their screening. And one thing that's cool for schools, you know, they have to do this all the time for their kind of annual school clearance. Now on the immunization section, it'll actually say they don't have TB risk factors, and they could just print that out. So that was really great. And then if they have a positive screen, now the question is, okay, how do we get, now we have to decide, okay, have they been tested or treated before, or should we send a test? And so again, a frustration for many is that there's not one kind of central place to find that information. And so we've created these specialty forms where one, you could see like past screening responses. And then there's these TB details section where providers can fill out kind of almost like a summary sheet that allows them to keep track and communicate with other providers, where you can say like they had a TST or tuberculous skin test, you know, a year ago, they did it, and they actually were already diagnosed with LTBI, and we treated them, right? And so if that's the case, you can say, okay, I'm done, and I don't need, unless there's a new risk factor, we can just move past it. If that isn't filled, or they haven't been tested before. So what happens if you go to the plan tab, there's something called best practice advisory that appears that'll say, you have a positive screen, consider ordering one of these tests. If they're under 2, we recommend a TB skin test. If they're 2 and older, interferon gamma release assay or a quantiferon gold. And or they can, you know, say, you know, give a reason why, like they've already been treated, they declined, or some other reason. And so this will hopefully again reduce the barrier to ordering the right test, because it just will be there. And there, you know, all this information can be pulled also into the note pretty easily, so that they don't have to do kind of double data entry into their documentation. And then the second workflow is, okay, you have a positive test. Now what do you do? Maybe that requires a little bit more clinical decision support, because that's not something people have to deal with on a day-to-day basis. And so how can we do that? Again, we have these smart forms that one will just help people keep track of the overall care for their patient and allow better communication with other providers. We kind of expanded this order set. So now there's a much larger order set now where you can do testing, because there's imaging, there's screening labs, treatment guidance, note templates, patient resources, referrals, and then there's some decision support here where we like have little, sorry, I don't know if my things is not really appearing, but oh, there it is. So you can see things like a 2-view chest x-ray is preferred if a TST or quantiferin is positive. So giving some kind of guidance to primary care providers. And then some note templates that can be used as well if they need it. And then we created a whole variety of patient resources with good feedback from community advocates that kind of how do we talk about TB in a culturally sensitive way and be language sensitive. So we have a whole range of languages that can also be printed in the after visit summary. And overall, we're starting the assessment now because we started in January and that was about like 8 months in, and overall screening has increased pretty significantly over time. And we did a baseline assessment prior to these tools, and about the big thing was a lot of people were screening, but not a lot of people were getting tests. And so only about 25%. And so now, we're at about 81% of individuals that have a screening are getting tested, which is really great. And overall, I think a big part is like people, all EHR tools comes with its things people like, and then there's a lot that they don't like, right? And so I think people's satisfaction is a big important part of this. And overall, people seem to be satisfied, especially with the screening and ordering. I think there's improvements in treatment and documentation completion that we can work on, but overall are improving. So now we're starting to extract the data from all these tools in order to kind of get a better sense of the care cascade and how we're doing. So last slide is really related to implementation. So none of these things should be done in a vacuum. And there actually is a digital health strategy that the WHO has set forth, saying that like if we want to do it, we need to be able to be thoughtful so that these tools are accessible and equitable, sustainable, and really respects the privacy and security of individuals' health information. Health system strengthening really is critical, right? Because you need to have the infrastructure in place to support these. And thinking about any given tool's feasibility, if you want to do an AHR program, you need to have a working electronic health record system in the network that you're working in, and that could be a heavy lift depending on the setting, and you need to plan that accordingly, or any of these other tools. And really, it needs to be patient and person-centered. So really making sure that we have the appropriate stakeholders, both from a public health perspective, but also the users and again the patients or caregivers. And an interesting and unique component of some of these, especially like AI tools, is you need to really monitor them over time, right? You might have seen just in popular media or things like that. It's like, unfortunately, depending on how they're trained, if they're not trained in an equitable or unbiased way, they really have created huge biases in prediction or errors if it's applied in different settings. So there needs to be really continuous monitoring of these tools to make sure that they're appropriately doing what you hope them to do, and have a system in place to update them, right? Because a lot of them might be based on X-rays, for example, that we're using one technology, but now the technology has shifted, right? And is that appropriate for this algorithm? So actually, this is something that from a regulatory standpoint is being thought through, is like, how do you actually create diagnostics or other tools that actually need to adapt over time and be updated, and how do you allow for that? So so in conclusion, hopefully I've shared that there is a lot of promise in some of these digital health tools, and both for TB as well as other conditions, and hopefully on a global health level can think about them being less specialized and more kind of how can it be integrated into more primary care and lower level facilities. And I think there's a variety of really exciting initiatives for improving TB care using these digital health tools. But at the same time, we just have to be mindful that there's a lot of opportunities, but really a lot of challenges in implementing these tools. And I think you need to, in parallel, make sure that they're safe and effective and unbiased and accessible to people, because then we're just going to have a lot of fancy things and they're not actually going to be used. So, but with that, I see there's a few things in chat, but thanks for your time. Oh, that's good. So yeah, I don't know if people have other experience or, people that have done, like Josh has done clinical decision work, or for all the pediatricians around me, like if they kind of see other challenges or opportunities that you've experienced or thought about for some of these.
We've actually been having a lot of conversations. Some of these topics around artificial intelligence, around decision support. I'm curious from the group what conversations have been.
Yeah, sure.
I'm wondering if you could expand a little bit on the security and privacy, especially of some of these digital biomarkers that you're talking about. It seems to come from what, as opposed to say just an image or text data, like sounds, but it's something
Yeah.
that other challenges.
Sure. Absolutely. So for the cough sound is a good example for that, right? Where if we're thinking about continuous monitoring, right, that itself sounds potentially scary as a terminology, right? And like, what is it recording and doing? And so for the cough sound, what we're doing is really just recording that explosive half-second period. So it's not continuously recording. The way it generally works is like if there's like a loud decibel sound that meets like, because like I said, coughs have this explosive period, like point. So if there's an explosive point, whether, honestly could be like construction noise, or it could be a cough. What happens is that like a half a second gets recorded, and then that gets analyzed. And if it's not a cough, then it gets deleted. And so that's one way about it, but you're absolutely right. You have to be thoughtful about like, what's it recording? We don't want to record people's conversations or collect other information, that is not valuable. But I think you're absolutely right. That's something we have to be mindful of. And you have to balance that with like, that's assuming that half a second is sufficient to do what you're going to want. In general, for cough sounds, that seems to be enough actually to classify a cough. But if we're trying to classify diseases or do other things, you may need more time, and we definitely have to balance that with the privacy needs for sure. No, I think it was just related to the screen sharing. Sorry, Fitz, if there was some issues.
I have a question.
Please.
First of all, that was just an awesome presentation. I have like 1,000 questions, so great,
Please.
really interesting. I had a couple questions. I was like, fire them out there. One was any work in helping people, in the early decision making of this cough is kind of different. I've seen a work out of Seattle Children's that kind of had people going through like a cough algorithm to then start to think about tuberculosis, at some stage in that. Like you wouldn't want to necessarily think about it on day one of a cough. That was kind of question number. Well, I'll stop there. That's my first question.
No, I think that's a great question. That I think like I said, cough in itself has, like in the context of COVID, has somehow exploded, right? And that people like the idea of this remote monitoring or self-testing, right? Where they could have a mobile phone app, they cough and it gives them some automated analysis to say, okay, this is your risk of having a more severe cough or a lower airway disease versus, unlikely, right? And helps people decide whether they should seek further care. And I think, so there is a huge interest. And I even think for what we're doing, right? So you can imagine it all comes down to what you're training on. Like, are you training on a TB diagnosis, which while it sounds nice, like I said, I think we need to be realistic. Like, do we think that a half-second cough is going to predict that disease perfectly? It may complement, non-specific clinical variables. And so that's thinking about that. But I think you're right. You could also train it to be like, for example, by a radiographic read, similar to the X-ray analysis, right? Where you're actually training it on abnormal X-ray. And you could say, okay, this is your probability that you have lower airway disease, and you should seek further care versus a more upper respiratory process. So definitely something that we're interested in, and not just us, but like I said, the whole world has really gotten excited about coughs for pneumonia, coughs for COVID or other kind of bronchiolitis, asthma exacerbation, COPD. You said you had another question, did you want?
Sorry, I can't see anyone there, so I don't know if anyone
yeah.
else has another question there.
I think so far, yeah, ready, keep going.
Okay, my other question was about care gaps, which was kind of new to me, but I practice also in the US. And you posed the question, like, why would this not be part of routine screening? The answer to me would be because you'd have like 50 care gaps. If everybody figured out how to do that, could you just kind of inbox burden type of issues? And then, one of the things that I always find interesting is people, like I do decision support and people will say like they like something or they don't. And what we found is like you really need to ask people, like, do they like care gaps at all?
Yeah.
And then the subset. So but it seems like you were able to overcome that with the great data on the usage. So maybe talk about like what do you think drove people to, like, for me, I'd be like, oh, another reminder,
Yeah, for sure. I mean, I think you always have to start with what the clinic's workflow is and how they use it or what they want. And so I actually had never heard of care gaps. I'm not a primary care provider, so I don't really use that on a regular basis. But then they were like, we use these care gaps all the time. And it's really helpful for us to keep track of things. And I think you're right, there could be a lot of care gaps. But the point is that at least for children, this is what they do. Like it's actually part of this clinic's note template to do, like to say, like, do they have any TB risk factors, yes or no? So it actually is already part of kind of the routine screening activity that they do. But you can maybe think about, a lot of this stuff is not specific to children. Like, why aren't we expanding this to adults, right? Which maybe have a higher proportion of latent TB infection if they're recent immigrants or they have other risk factors. And that's a harder question, right? Because there actually aren't really recommendations for when they should be screened. It's about like risk factors. And some people have tried to do that by like extracting data from other parts of the EHR. So, for example, country of origin is often a frequent trigger, but a lot of these health systems, including Epic, don't really ask that question. One, there's like proxies like preferred language or ethnicity that are imperfect and infrequently entered or incomplete. And then two, there's a lot of kind of privacy issues around that, in that some providers and patients really don't feel comfortable giving their country of origin. There's concerns around immigration status or other things. And so you just have to be sensitive to those issues. And so how do you adapt now this to adults in terms of kind of when to screen? Do you give everyone a one-time lifetime screen? Do you just give them a survey? Like, that's the other thing, is like a lot of the feedback we've gotten is like, yes, to your point, like, I don't want to deal with one more screener, right? That's the number one feedback. And so one is task shifting a little bit, maybe to MAs or nurses that, again, for example, in pediatrics, they're doing like screening for hearing and vision. This is 4 questions, could they add that to it? But they might say, no, we can't, we already do a bunch of other stuff. And then, so then the next shift is, can patients or caregivers do it? And so my chart, which is the Epic's kind of portal, but every health system has a similar portal, do have survey questions that they push to them. And currently, actually, caregivers can see that there's a care gap right now in this. And actually, it's been kind of interesting secondary effect where they've sent messages being like, I have this TB care gap, what's this about? Which has been a nice education point. But the next step would be like, you can imagine you could easily take these questions, put it on as a survey prior to their visit, they fill it out, and then, when they come, it's really just the alert that comes up that says, hey, they answered that they had a care gap, or they had a risk factor.
Having known you for a little bit and knowing you in fellowship, you have also looked at diagnosing TB, urine and saliva. I'm curious if you can put digital health diagnostics in that spectrum.
Sure.
And whether you think for peds, and maybe specifically if this is really where you see the future heading versus some of those other tools.
Sure. Maybe just to repeat the question for those online, it's really, how does the digital biomarker fit within the spectrum of other biomarkers and diagnostics. And, definitely, I still continue to do all that work in terms of, so I'm part of, I didn't talk about it today, but I'm part of a large kind of multi-center initiative to look at non-sputum biomarkers for TB diagnosis, which includes urine and blood. We also do breath-based diagnostics and a variety of other tools for children. And we included digital health really, I think, fits well in all of those. I think in my perspective, each one of them has its role and advantages, limitations, right? Like some of these tools, like I said, digital health tools have a lot of advantages in relation to urine and plasma, like I said, from just like how do we, like from a non-invasive standpoint, and also how do you get multiple groups involved? Like I said, the fact that you could have like, a bank of cough sounds and you could work with 4 or 5 different groups, right? That's a lot harder with like a much more finite volume of definitely blood and to some extent urine in children, which is hard to obtain. It's going to be invasive. You have to make sure that it's at a certain kind of storage and bring it over, all these things. So there's definitely a lot of advantages. But at the same time, what are the limitations of all these tools? Are you going to get the specificity that you need for TB or whatever disease? So that's where looking at more TB specific biomarkers in plasma and urine might be more valuable in that situation. And maybe the test use for these are more in the screening, triage, part of it, an algorithm, a part of a clinical algorithm where it's supporting, how do we improve all our bad auscultation skills by making the digital stethoscope a more valuable tool. So yeah, I view them all as valuable. And it's, again, I don't think the reality is that there's going to be some silver bullet that diagnoses every kid, with one test. I think it's going to be still require a combination of the risk factors, symptoms, and then hopefully you can imagine a pathway in which there's some initial tools that increase our sensitivity, get as many kids as possible into care and getting through some of these testing, and then more specific tests that can, further confirm the diagnosis, again, hopefully close to the point of care in a non-invasive way.
I would like to ask a question about the CAD. Because I work in the HIV field. Sometimes we need to have an X-ray. It's very difficult to have it, even though we can find it. Sometimes the radiologist is not available to interpret and to send the report. Is it something accessible? And about the price and how it works, I would like to have more information about it. Yeah. I saw what you share, but I don't know exactly. Is it something we use to see in the screen, or we have this
Sure, I can pull up that picture maybe just to kind of have a visual to it. Yeah, for sure. So it's a general question is around CAD and kind of some of the logistics around it in terms of its implementation, cost, and other factors. So there are a few commercially available CAD systems, and the cost is a combination of the license for the actual CAD software plus the cost of these X-ray machines. Now, there's variation though. This is like a nice ultra portable kind of a model, but you can use digital X-rays, meaning like if someone has a digital X-ray machine that gets DICOM images, that's also can be used. You can adapt analog X-ray machines to be converted to digital images, or one of the interests that we have also is just digitizing film, right, which is more common in many settings, whether that's taking a photo or using a scanner to then upload into those systems. So part of the cost is the actual machine, right, and part of this depends on your particular need, right. You can imagine this is not maybe the best on a mass screening tool, right. You're gonna, you might need a more high throughput device than this if you're doing it. This has portability advantages. So I think part of the cost is the actual X-ray device, and then there's a variety of licenses that are available depending on the vendor that you have, for which public health, ministries of health, are kind of negotiating or trying to discuss kind of with these. And in terms of your particular purpose, I think it speaks to, a lot of these kind of give out a TB score because that's maybe where the funding and support and focus is on. But, I think from definitely a pediatric perspective, I think having a list of abnormalities is actually pretty valuable, right? I think knowing whether there's just a consolidation or an effusion or pyelolymphadenopathy or something is actually extremely valuable for that initial evaluation and helps decide, okay, I'm going to set these list of tests, some of which are related to TB, but of course, maybe I need to look at other causes of, hyelolymphadenopathy in a child. And then the other piece of it is like kind of severity related to TB, because some may be familiar that recently there's been a motivation to lower the duration of TB treatment to 4 months from 6 months for children through this trial called the SHINE trial. But that's guided by kind of severe versus non-severe disease. So you may diagnose them with TB, but then you need to make a decision about whether to give them a short course or a longer course. And so again, an X-ray read that gives you a sense of severity of disease, I think would also be valuable.
Thank you.
I know we're kind of at the top of the hour, so I don't know if there's any other questions.
Thank you.
Yeah, no, thank you for your time, and feel free for others that would like to reach out or you're interested in any of these topics and want to get involved, let me know.
And,
Great talk.
we have a
Thank you.
short survey for everyone in the audience. If you could take a moment to fill it out, just 3 quick questions.